Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic, that is the anaphylaxis. So, you need to know what is anaphylaxis. Anaphylaxis, it is a potentially life-threatening systemic allergic reaction. Okay, so it is life-threatening systemic allergic reaction. Okay, so that is what is your anaphylaxis. And when I am using the word systemic allergic reaction, it involves one or more organ systems. So there will be involvement of more than or equal to there will be involvement of more than or equal to one organ system. Okay, and that typically occurs within seconds to minutes after the exposure of the allergen. So this life-threatening allergic reaction, it occurs within seconds to minutes after the exposure to the allergen. That is what is called as the anaphylaxis. Now, you need to know what is that particular allergen or what are the triggers for anaphylaxis. Most often, the triggers for the anaphylaxis include a drug, food, or a bee sting, that is Hymenoptera sting. Okay, so these are the triggers for anaphylaxis. And apart from these, we also have other triggers of anaphylaxis. And what are the other triggers? Right, what are the other triggers? The other triggers include radio contrast administration or the latex exposure. Right, radio contrast administration or the latex exposure. Alright, so that is about the triggers for the anaphylaxis. Then, followed by that, you need to know the predisposing factors and etiology for the development of anaphylaxis. See, because the most dangerous manifestation of anaphylaxis involve the cardiovascular and as well as respiratory system. So, cardiovascular in the sense there will be hypotension, and respiratory system in the sense there will be bronchoconstriction. So, the predisposing factors for the development of anaphylaxis include the presence of pre-existing asthma, right, the presence of the pre-existing asthma and the presence of underlying cardiovascular disease. Right, and the presence of an underlying cardiovascular disease. So this could lead to more rapid decompensation from the anaphylaxis. So these are the predisposing factors for the anaphylaxis. And let me tell you, the presence of atopy, it is not generally thought to be a risk factor for anaphylaxis. That is, the history of allergy is not generally thought to be a risk factor for anaphylaxis. Okay, but this anaphylaxis, it is associated with radio contrast sensitivity. Now, you need to know what are the cells that will mediate the anaphylactic reaction. Many of the important early mediators of anaphylaxis, they are derived from the mast cells. Right, they are derived from mast cells. Then the basophils, right, and then the eosinophils. Okay, so these are the cells that will mediate the anaphylactic reaction. Now, you need to know what are the mediators for anaphylaxis, right? You take the cells we have discussed, mast cells, basophils and eosinophils. Okay, so mast cells and basophils, right, mast cells and basophils, they contain the preformed granules comprised of the histamine and proteases. Okay, they contain the preformed granules, right, and this preformed granules contains the histamine and proteases, right, and what are the examples of these proteases? That includes the tryptase and as well as the chymase, right, tryptase and chymase. So these are the proteases which are the mediators of the anaphylaxis, okay, and histamine. Now, apart from the histamine and proteases, we also have the other substances that includes the proteoglycans, right, the proteoglycans and as well as the TNF alpha. Now, what will be the examples of these particular proteoglycans? That includes the heparin and the chondroitin sulfate, right, the heparin and as well as the chondroitin sulfate. So these are the proteoglycans. They also act as the mediators for anaphylaxis. Now, these are rapidly released into the surrounding tissue upon the cell activation, right? So these are the substances that will be rapidly released. Right, these are the substances that are rapidly released upon cell activation. Okay, and this particular process is known as degranulation. Right, this particular process is known as degranulation. Okay, so mediators for anaphylaxis includes the mast cells, basophils and as well as the eosinophils. And let me tell you, see, I have discussed these are all the mediators for anaphylaxis. That includes histamine, proteases, the proteoglycans, right? They are released upon degranulation. Now, apart from these, right, apart from these mediators, mast cells, basophils, eosinophils, they are also the sources of arachidonic acid derived products, right? They are also the sources of right, they are also the sources of arachidonic acid derived products. And what are the examples of this arachidonic acid derived products? Which includes cystinyl leukotrienes, right, that includes cystinyl leukotrienes, then the prostaglandins, then followed by that the platelet activating factor. So these are the arachidonic acid derived products that include cystinyl leukotrienes, prostaglandins and as well as the platelet activating factor. Now, after having discussed about the mediators, now you need to know what is the effect of these particular mediators. Like for example, you take this particular, the histamine. Histamine release results in flushing, right? So this will cause flushing, right? This will cause urticaria, and pruritus. So these are the effect of the histamine: flushing, urticaria and pruritus. And these histamine, whenever it is produced in high concentration, right, whenever it is produced in high concentration, that will cause the hypotension and tachycardia. Right, that will cause the hypotension and tachycardia. So these are the effect of the histamine. And then we have discussed other mediators, that includes cystinyl leukotrienes and as well as the prostaglandins. See, cystinyl leukotriene and prostaglandin D2, it causes bronchoconstriction. Right, it causes bronchoconstriction and increased microvascular permeability. Right, increased microvascular permeability. Okay, so that is the effect of the cystinyl leukotrienes and as well as the prostaglandin D2. And particularly if you take the prostaglandin D2, right, particularly if you take the prostaglandin D2, this will cause the cutaneous flushing. Right, this will cause the cutaneous flushing and it attracts the eosinophils and basophils to the site of the mast cell activation. Okay, so this will attract eosinophils and basophils to the site of the mast cell activation. So that is about the effect of cystinyl leukotriene and prostaglandin D2. So what was your histamine causing? Histamine, it will cause flushing. Even flushing is also caused by your prostaglandin D2. Histamine will cause urticaria and as well as pruritus. And in high concentration, histamine was causing hypotension and tachycardia. Whereas the cystinyl leukotriene and prostaglandin D2 together, they will cause bronchoconstriction and as well as increased microvascular permeability. But prostaglandin D2 alone will cause the cutaneous flushing and attracts eosinophils and basophils to the site of the mast cell activation. And a very important question here is, which particular mediator correlate with the anaphylaxis CVRT? The mediator which will correlate with the anaphylaxis CVRT is serum platelet activating factor levels. Okay, it is serum right, it is the serum platelet activating factor levels that correlates with the anaphylaxis CVRT. Okay, next, then we have proteases, that is tryptase and as well as chymase. What are the effects of the tryptase and as well as chymase? Tryptase and chymase can activate the complement and coagulation pathway. So both of these substances, right, both of these substances, they activate the complement and the coagulation pathway. Right, they activate the complement and the coagulation pathways. Now activation of these pathways will result in the production of anaphylactotoxins or anaphylatoxins. So activation of these particular complement pathways will result in the release of will result in release of the anaphylotoxins and release of C3A and C5A. Okay, release of C3A and as well as C5A. Now, apart from that, this tryptase and kinase will also cause the activation of the kallikrein-kinin system. Right, will also cause the activation of will also cause the activation of kallikrein-kinin system. And this kallikrein-kinin system, it is the one which regulates the blood pressure and vascular permeability. Okay, so this regulates the blood pressure and the vascular permeability. Okay, so that is what the kallikrein-kinin system does, right? And the action of these anaphylactic mediators are likely additive or synergistic at the target tissues. Okay, so these two, they will have additive effect together, right? These two will cause the additive effect together at the target tissues. Okay, so these are the effect of your mediators. So the mediators that are being released is the histamine. The histamine will cause flushing, urticaria, pruritus, and high concentration they will cause, or histamine will cause hypotension and tachycardia. And next important mediators is cysteinyl leukotrienes and prostaglandin D2. These two together will cause bronchoconstriction and increased vascular permeability. And prostaglandin D2 alone will cause cutaneous flushing and attracts basophils and eosinophils to the site of the mast cell activation, right? And it is the platelet activating factor that will correlate with the anaphylaxis severity. And if you take the tryptase and as well as chimases, they activate the complement and coagulation pathways that will result in the production of anaphylatoxins C3A and C5A release. And there is also activation of kallikrein-kinin system which regulates the blood pressure and vascular permeability. And the action of these anaphylactic mediators are likely additive or synergistic at the target tissues. Okay, next. The next question is, what is non-IgE mediated reactions? Let me tell you, these are all the drugs which will cause, right, which will cause non-IgE mediated reactions. Let me tell you. See, this non-IgE mediated reactions to certain drugs, it can mimic the pathophysiology of, right, it can mimic the pathophysiology of IgE dependent anaphylaxis, right, it can mimic the pathophysiology of IgE dependent anaphylaxis due to a similar profile of mediators. You take this paclitaxel. What is this paclitaxel? Paclitaxel, it is a chemotherapeutic agent. Right, it is a chemotherapeutic agent and it is derived from yew tree bark. Right, it is derived from the yew tree bark. Okay, and that is what is responsible for non-IgE mediated reactions. Then we have another substance called as the chemophore. Chemophore, it directly activates the complement cascade. Right, it directly activates the complement cascade, resulting in complement dependent induced histamine release from mast cells and as well as basophils. So basically, this chemophore will also cause the release of the histamine. Right, will also cause the release of the histamine from the mast cells and basophils. Okay, that is what, okay, from right, from the mast cells and as well as basophils. So that is what the chemophore does. And the another drugs which are responsible for your non-IgE mediated reaction is the radio contrast agent and as well as vancomycin. Okay, so this radio contrast agent mainly we use during the coronary angiography, or this radio contrast agent is mainly used during high resolution CT scan, or the radio contrast agents, they are used during the imaging purpose like MRI. So even these radio contrast agents whichever are used for diagnostic purposes are also responsible for non-IgE mediated reaction. Then the other group of drugs which are responsible for your non-IgE mediated reaction is opiates and NSAIDs. These are other drug categories that have similar adverse reaction. So that is about the pathogenesis for the anaphylaxis. Now let me discuss what will be the clinical manifestations in patients with the anaphylaxis. Anaphylactic episodes, they are either uniphasic or biphasic. Okay, 80 to 90% of the anaphylactic episodes, they are uniphasic, right? So 80 to 90% they are uniphasic. Now what do you understand by the word uniphasic? A uniphasic response typically peaks within hours right, the response, it peaks within hours after the symptom onset, okay, right, after the symptom onset, right, the response, it will peak within hours and then either resolve spontaneously or after the treatment. Okay, so this uniphasic response, this will resolve spontaneously or it will resolve after the treatment, and this resolution will occur within hours. Right, this resolution will occur within hours. And you take the biphasic response. Biphasic response, it occurs in about 10 to 20% cases of the anaphylaxis, right? And this biphasic response is that in which the anaphylactic symptoms return about an hour or longer after the resolution of the initial symptom. So first they will have the initial symptom, right? There will be initial set of clinical manifestation, right? And for after more than hour, okay, these initial symptoms, they undergo resolution, right? They undergo resolution. After more than 1 hour, these symptoms will return back. Right, these symptoms will return back. That is what is nothing but your biphasic anaphylactic reactions. Okay, now so majority of them, 80 to 90% of them, they are uniphasic. 10 to 20% of them, they are biphasic. Okay, now the question is why why anaphylactic reactions are dangerous. Anaphylactic reactions are particularly dangerous when hypotension or hypoxia occurs. Okay, so they are dangerous when, right, when hypotension or hypoxia occurs. That is the point when these anaphylactic reactions are dangerous. Okay, and these anaphylactic reactions, they lead potentially to cardiovascular collapse or respiratory failure respectively. Okay, so this hypotension is mainly because of the cardiovascular collapse, whereas this hypoxia, it is the one due to respiratory failure. Right, it is the one due to respiratory failure. Okay, and let me tell you, regarding the respiratory tract involvement, right, regarding the respiratory tract involvement, there may be upper or lower airway obstruction, or it may be even both. Okay, so regarding the respiratory tract involvement, there is either lower or upper respiratory tract involvement. Or there can be involvement of both. Right, or there can be involvement of both. So this is about the why anaphylactic reactions are dangerous, because there is respiratory arrest and as well as there is also the cardiovascular collapse. And not only that, the other reasons which are the responsible for the anaphylactic reactions being very dangerous is the laryngeal edema. See, this laryngeal edema may be experienced as lump in the throat. Right, they are being experienced as lump in the throat, okay, or they are being manifested as the hoarseness or stridor. Okay, so that is about the laryngeal edema. Then another important manifestation is bronchial obstruction. See, this bronchial obstruction, it is associated with a feeling of tightness in the chest. Right, that is being manifested as the feeling of tightness in the chest, or there can be audible wheezing. Right, there can be audible wheezing. So that is about the bronchial obstruction. Right, so I am explaining you why the anaphylaxis is dangerous. There can be either hypoxia due to respiratory failure, or there can be hypotension due to cardiovascular collapse. And the other reasons why the anaphylaxis is dangerous is these individuals can develop laryngeal edema and these individuals can develop the bronchial obstruction. And that bronchial obstruction will manifest as tightness in the chest or the audible wheeze. Then, so we have discussed that the respiratory tree involvement, either it will be upper respiratory tract or lower respiratory tract being involved. And you take the lower airways. Patients with underlying asthma are predisposed to severe involvement of lower airways. Okay, so patients with history of asthma, right? Patients with history of asthma, they are predisposed to severe involvement of the lower airways. Right, severe involvement of the lower airways, and these individuals, they have increased mortality associated with anaphylaxis. Right, these individuals, they are associated with increased mortality associated with anaphylaxis. Okay, that is about the lower airway involvement. So patients with underlying asthma are predisposed to severe involvement of the lower airways. Then you take the lung involvement, that is same respiratory tract involvement. In fatal cases with clinical bronchial obstruction, the lungs, they show marked hyperinflation on gross and microscopic examination. So when you do a the examination of the lung, that will be marked hyperinflation of the lung, or this marked hyperinflation that is on gross and microscopic examination of the lung. Okay, so that is about the lung in patients with the anaphylaxis. So now let me discuss the microscopic findings of the bronchi and in bronchial asthma with anaphylaxis. So microscopic findings that includes the presence of the luminal secretions, and this luminal secretions, this can be even the gross finding as well, but there will be presence of the peribronchial congestion. Right, there will be presence of the peribronchial congestion. Okay, and this peribronchial congestion and as well as the submucosal edema. These are the microscopic findings within the bronchi with anaphylaxis, and you will also observe the presence of the eosinophilic infiltration. Right, you will also observe the presence of the eosinophilic infiltration. Then finally, what is the cause of death in these patients with the anaphylaxis? It is mainly the angioedema resulting in death by mechanical obstruction. Okay, so it is angioedema and this angioedema, it will result in death. How is that? That is by mechanical obstruction. Right, that is by mechanical obstruction, and this angioedema, it mainly occurs in the epiglottis and as well as the larynx. Right, in the epiglottis and as well as the larynx. However, the process also is evident in the hypopharynx and to some extent even in the trachea. Okay, so this process of angioedema, to some extent it is also evident in hypopharynx and to some extent even within the trachea. Right, to some extent even it is evident within the trachea. So that is about the cause of death. And if you take the microscopic examination of these particular structures, on microscopic examination there is widespread separation of the collagen fibers and glandular elements. Right, widespread separation of collagen fibers, and there will be also widespread separation of the glandular elements. So this is one of the microscopic examination of that particular angioedema. And not only that, you will also observe the presence of vascular congestion and eosinophilic infiltration. Right, vascular congestion, and there will be infiltration of the eosinophils. Right, so eosinophilic infiltration. Okay, so this will be the microscopic examination findings. Now, see, one cause of death is due to the angioedema, right? And where was that angioedema, and what was this angioedema causing? Mechanical obstruction. And that mechanical obstruction, it occurs in the epiglottis and as well as the larynx. And not only that, even this particular process also is evident in the hypopharynx and to some extent even within the trachea as well. Now, the death can also occur due to vascular collapse, and patients dying of vascular collapse without antecedent hypoxia from respiratory insufficiency, these individuals, they have visceral congestion with a presumptive loss of intravascular fluid volume. So, these individuals with vascular collapse, there is loss of intravascular, right, loss of intravascular fluid volume, right, loss of intravascular fluid volume, okay. And these individuals, they have visceral congestion, right. So, the visceral organs, like you take liver, kidney, spleen, cardiac involvement, heart. So, in these areas, there will be visceral congestion with presumptive loss of the intravascular fluid volume, right. And what will be the associated electrocardiographic abnormalities? The electrocardiographic abnormalities you will observe with or without infarction, right. You will observe with or without infarction, and in some patients it may reflect a primary cardiac event mediated by the mast cells. Actually, why is this particular visceral congestion and why is that particular cardiovascular collapse? It is the cardiac event which is mediated by the mast cells, right. It is a cardiac event which is mediated by mast cells, okay, which are prominent near the coronary vessels, okay. So, this cardiac event which is mediated by the mast cells, it is near to the right, it is near to the coronary artery, okay. So, this is about the reason for death, that is vascular collapse. So, one of the cause, it would be angioedema, right, of your epiglottis or the larynx. The other reason for the death would be the vascular collapse. Now, what will be the gastrointestinal manifestation in these patients with anaphylaxis? Gastrointestinal manifestations represent another severe presentation of anaphylaxis, and that includes nausea and as well as the vomiting, right. And apart from that, these individuals, they also have crampy abdominal pain, right. They also have crampy abdominal pain, and there will be also fecal incontinence, right. There will be also fecal incontinence. So, this will be the gastrointestinal manifestations. So, why do you think that these gastrointestinal manifestations will be there? That is due to angioedema of the bowel wall. Right, that is due to angioedema of the bowel wall, okay. So, this may also cause sufficient intravascular volume depletion to precipitate the cardiovascular collapse, okay, because once there is angioedema of the bowel wall, the absorption of the fluids or the nutrition across the GIT does not occur, and thereby there will be intravascular volume depletion, right. Thereby there will be intravascular volume depletion, right. and even that can also precipitate the cardiovascular collapse. And apart from all these, you need to know, or if the question is asked, what will be if the question is asked, what will be the most common presentation of anaphylaxis? That is the cutaneous manifestations. So cutaneous manifestations, right, you can see that here the cutaneous manifestations are among the most common presentation of anaphylaxis, and these cutaneous manifestations, they are seen in almost more than 90% of cases of the anaphylaxis. And what will be that symptoms? The symptoms include urticarial eruptions, right? The symptoms include urticarial eruptions, okay? And apart from this, right, apart from this, flushing with diffuse erythema is another important manifestation, okay? Flushing with diffuse erythema, so in the sense that is redness of the skin, right? So flushing with diffuse erythema and a feeling of generalized warmth is another important manifestation. Right, it is another important manifestation of the anaphylaxis. And these urticarial eruptions are intensely pruritic, right? So these urticarial eruptions, they are intensely pruritic, right? That means these individuals, they have, a very severe itching, and these urticarial eruptions which are pruritic, they may be localized or disseminated throughout the body. Right, or disseminated throughout the body. So that will be the most common presentation in the anaphylaxis. And apart from that, there can be presence of the giant hives, right? What are these giant hives? These cutaneous manifestations, that is whatever are there, these urticarial eruptions, whatever are there, all of them, they coalesce, right? All of them, they coalesce. So once they coalesce, that will result in the giant hives, right? But they seldom persist beyond 48 hours. But they seldom persist beyond 48 hours. Okay, so that will be the giant hives, and that will be the most common presentation. Which one? The skin manifestation. Now, coming to the diagnosis. So in the diagnosis, history is very important. The diagnosis of an anaphylactic reaction depends primarily on a history revealing the onset of the signs and symptoms. Okay, so the history tells you that the onset of the onset of the signs and symptoms within seconds to minutes. Right, within seconds to minutes after a putative trigger is encountered. So within seconds to minutes of a putative trigger is encountered, there will be onset of signs and symptoms. That history is very important for the diagnosis. And we also have an exception. Right, we also have an exception. An exception is delayed anaphylaxis to meets in alpha-gal sensitized patients. So exception is exception is delayed anaphylaxis, and this particular delayed anaphylaxis is to the meets in it is to meets in the alpha-gal sensitized patients, right? and every attempt to identify the specific cause or causes should be made so as to minimize the risk of the recurrent anaphylaxis. So you should be able to identify the triggering agent. Okay, so once you identify this particular trigger, right, that will minimize the risk of recurrent anaphylaxis. Right, that will minimize the risk of recurrent anaphylaxis. So that is about the history. And apart from that, investigations, that is skin or serum specific IgE testing. See, if a particular drug or if a particular food is suspected, skin or serum specific IgE testing is useful to confirm the clinical suspicion. So the skin or serum specific IgE will confirm, right, this will confirm clinical suspicion. Okay, next, if a specific trigger cannot be identified, a workup of underlying atopic diathesis may be useful to identify the risk factor. Okay, so you need to do workup, right? You need to do workup of underlying atopic diathesis. Right, workup of underlying atopic diathesis may be useful to identify the risk factors that could play a potential contributory role. So that is about the skin or serum specific IgE testing. Then coming to the laboratory biomarkers. See, in the acute setting, laboratory biomarkers of mast cell degranulation may be useful to document the severity of anaphylactic episode, right? So whenever these mast cells, when they undergo degranulation, right, when they undergo degranulation, they will cause the release of the histamine, right? They will cause the release of the histamine. Okay, and the quantity of the histamine which is being released, right, the quantity of the histamine that is being released, that will assess the severity of the anaphylactic episode. Right, that will assess the severity of the anaphylactic episode, right? And among this, the most obvious serum biomarker to assay is the histamine, right? But the disadvantage of the histamine is that the half-life, it has a very short half-life, right? It has a very short half-life with a measurable time window that expires less than 1 hour from the onset of the anaphylaxis. So the half-life is less than 1 hour. That is a disadvantage. So by the time the patient presents to you, by the time you collect the sample and send it to the laboratory, if it is like less than 1 hour, the histamine in the blood sample is being degenerated. Then another important laboratory biomarker is the tryptase. Tryptase, it is a more practical and useful biomarker, right? So this tryptase, it peaks, right? It peaks 60 to 90 minutes after the onset of anaphylaxis. right? So it peaks 60 to 90 minutes after the onset of anaphylaxis, okay? And it can be measured as long as 5 hours after the onset of anaphylaxis, okay? So it can be measured as long as 5 hours after the onset of the anaphylaxis, okay? So that is about the tryptase, right? This is more practical and useful biomarker, that is serum tryptase, which will peak within 60 to 90 minutes after the onset of anaphylaxis and can be measured as long as 5 hours after the onset of the anaphylaxis, right? And this particular tryptase, it may be used or it may be useful to follow up an elevated tryptase measurement in the acute setting with another measurement when the patient is clinically stable to establish the baseline reference. So, this is also useful for follow-up. What do I mean by that? See, during an anaphylactic episode, right, definitely the levels of the tryptase will be increased. Okay, and at the same time, you should also do, once the anaphylactic episode is over, right, once the anaphylactic episode is over, then you also need to do the baseline value, right? You also need to do the baseline value, okay? So, this elevated, for example, even in the baseline, that means the individual is not having any anaphylactic episode. An elevated baseline tryptase level may warrant further workup for mastocytosis. So, if the baseline value is elevated, right, that tells you that the individual is suffering with, or the individual might be suffering with mastocytosis. Okay, so that is the importance of an elevated baseline tryptase levels. Okay, and this elevated baseline tryptase levels may warrant further workup for mastocytosis, especially if the presenting reaction occurred in the setting of the Hymenoptera sting. So, in the sense, the Hymenoptera sting this is also responsible for the elevated tryptase levels. So, to summarize about the tryptase, it is a more practical and useful biomarker. It peaks within 60 to 90 minutes after the onset of anaphylaxis, and it can be measured as long as 5 hours after the onset of anaphylaxis. And it may be useful to follow up an elevated tryptase measurements in the acute setting with another measurement when the patient is clinically stable to establish the baseline reference. See, baseline value you have to do when the individual is clinically stable. If an elevated baseline tryptase levels is there, that may warrant further workup for mastocytosis, especially if the presenting reaction occurred in the setting of the Hymenoptera sting. Then, so after the investigations, so investigations first important is history, right? Then skin or serum specific IgE testing. Then histamine, but the histamine disadvantage is it has a short half-life of less than 1 hour. Then the measurement of the tryptase levels. So the tryptase levels or tryptase will peak within 60 to 90 minutes after the onset of anaphylaxis, and it can be measured as long as 5 hours after the onset of anaphylaxis. Okay. Now coming to the treatment of choice. So early recognition of an anaphylactic reaction is mandatory, since severe fatal complications can occur within minutes after the symptoms first appear. Okay, so early recognition is very important, otherwise you will have to see the fatal complication, and that will appear within minutes after the symptoms first appear. And the treatment of first choice is intramuscular administration of 0.3 to 0.5 ml of 1:1000 dilution of epinephrine. Okay, so that will be the dosage of the epinephrine, right? Intramuscular administration of 0.3 to 0.5 ml of 1:1000, that is 1 milligram per ml epinephrine. Okay, and you have to repeat the dose right? You have to repeat the dose at 5 to 20 minutes interval. Right? You have to repeat the dose at 5 to 20 minutes interval as needed for a severe reaction. Okay, if there is severe reaction, then you have to repeat a dose at 5 to 20 minutes interval. And the failure to use epinephrine within first 20 minutes of symptoms is a risk factor for poor clinical outcome. So, you have to give this epinephrine within 20 minutes. But if you have given epinephrine, right, but you have given epinephrine after 20 minutes, then there is risk of the poor clinical outcome. Right, there is risk of poor clinical outcome in various studies of the anaphylaxis. So that is about the treatment of choice, which is nothing but your epinephrine. Now, what is the advantage of epinephrine? See, epinephrine provides both alpha and beta adrenergic effects. Right, it provides both alpha and beta adrenergic effects. Okay, and because of both alpha and beta adrenergic effects, that will result in the vasoconstriction, right, and that will also cause the bronchial smooth muscle relaxation, and because of bronchial smooth muscle relaxation, the individual will have the development of bronchodilation. Right, the individual will have the development of bronchodilation. And the another important advantage is attenuation of enhanced venular permeability. Right, attenuation of venular permeability. So, the venular permeability will be reduced and thereby there will be increase in the intravascular volume. Okay, so that is the advantage of the epinephrine acting on both alpha and as well as the beta receptors. Now we have a clinical entity called empty heart syndrome. See, whenever you are administering the epinephrine in a patient with anaphylaxis, the posture of the patient is very important. Okay, what is that? Let me explain you. See, the body posture, right, if the body posture of the individual with anaphylaxis, if he is either in upright position or in the sitting posture, right, the patient with the anaphylaxis body posture, if it is like upright or sitting posture, that may lead to the empty heart syndrome. Why? Because in upright or sitting posture, there is insufficient venous return. Right, there is insufficient venous return. So this insufficient venous return to the heart from sudden onset hypotension secondary to intravascular volume depletion. So, why there is insufficient venous return? Because in patients with anaphylactic reaction, what is happening? There is increase in the vascular permeability. So, the fluid from the intravascular compartment will go to the extravascular compartment. So, that insufficient venous return, it is due to intravascular volume depletion. Right, it is due to intravascular volume depletion. So, this epinephrine, it can further accelerate the empty heart syndrome. See, already when the individual is in upright or sitting posture, there is insufficient venous return to the heart. And apart from that, whenever you are giving this epinephrine, what will this epinephrine do to the heart rate? It will increase the heart rate. That means it has the chronotropic effect. So it will try to empty the heart. Already the heart is empty. The heart is suffering with decreased venous return. So epinephrine can further accelerate the empty heart due to its chronotropic effect. Okay. So this epinephrine, it will further precipitate the empty heart syndrome. For this reason, it is recommended that patients who suffer from anaphylaxis, right? For this reason, patients who suffer from anaphylaxis, they have to be placed in supine position. Right? These patients, they have to be placed in supine position before receiving the epinephrine. Right? Before receiving the epinephrine, they have to be placed in supine position, because in supine position, the gravity will not be there. So the venous return will improve. Right? And the patient should not be placed in upright or sitting posture. Next, which antihypertensives attenuate the response of epinephrine? So it is the beta blockers. Right, it is the beta blockers. So beta blockers will reduce or may attenuate this response. Therefore, an alternative antihypertensive may be considered in patients at high risk of needing the emergency epinephrine. Okay. So when the individual is on beta blocker, please stop that particular beta blocker. Right. They will attenuate the response of epinephrine, because epinephrine will act on alpha and beta receptors, and your beta blockers are blocking your beta receptors. So thereby the response of epinephrine, it gets attenuated. And the next important question is how to treat if intractable hypotension occurs. That means if it is like irresistible hypotension, then you need to give IV fluids and vasopressor agents. Right, IV fluids and vasopressor agents may be administered in the acute medical setting if intractable hypotension occurs. That means in spite of giving your epinephrine, right, if the hypotension persists, then you need to give IV fluids, and as well as some other vasopressor agents like your vasopressin and all have to be administered. So how is this oxygen delivery done in anaphylaxis? Oxygen alone via nasal catheter or via nebulized albuterol may be helpful. Okay, it is given via nasal catheter or with nebulized albuterol. Okay, so these may be helpful. However, either endotracheal intubation or tracheostomy is mandatory for oxygen delivery if progressive hypoxia develops. So in spite of giving oxygen via nasal catheter, for suppose if there is progressive hypoxia, right, if there is progressive hypoxia, then endotracheal intubation, right, or tracheostomy is mandatory. Okay, so that is how the oxygen delivery is done in patients with anaphylaxis, right? Next, followed by that, you need to know what are the ancillary agents that are given in patients with anaphylaxis. Ancillary agents such as antihistamines, then followed by that the glucocorticoids, right, and bronchodilators, they are also useful therapeutics. Okay, so these are the drugs which are given to treat urticaria or angioedema and bronchospasm once the patient is hemodynamically stable. So once the individual is hemodynamically stable, then these drugs, they are given to maintain or to treat the urticaria, right, or the angioedema, and bronchospasm. Okay, so these are the drugs that you have to give in the individuals who are hemodynamically stable. Next, coming to the prevention, that is avoidance. The simplest, most straightforward approach to the long-term management of patients with history of anaphylaxis is strict avoidance of known anaphylactic triggers. Okay, so whatever are the anaphylactic triggers are there, these anaphylactic triggers, right, these anaphylactic triggers, they have to be educated to the patient, and the patient should avoid these anaphylactic triggers. Okay, and the individual, the patient also has to be educated about the proper use and indication for the self-administering epinephrine. Okay, so have to be educated about the proper use and indication for the proper use of self-administered epinephrine. Okay, that is about the avoidance. So anaphylactic triggers, whatever are there, they have to be educated to the patient and they should be avoided, and at the same time the proper use and indication for use of self-administered epinephrine has to be taught to the patient. Then next, about the VIT, that is venom immunotherapy. See, patients with large, so I'll tell you in which group of individuals you need to give VIT. Patients with large local reaction to Hymenoptera stings, right, large local reaction to large local reaction to Hymenoptera stings, they are unlikely to have anaphylaxis with subsequent stings, right? They are unlikely to have anaphylaxis with subsequent stings. However, patients of any age who have had documented anaphylaxis should be formally evaluated and started on this venom immunotherapy. If skin or serological IgE testing confirms the history. So in those individuals who have this history of the Hymenoptera sting, how can you make out that there is a past history of Hymenoptera sting? You need to do skin or serological skin or serological IgE testing confirms the history. In the case of the Hymenoptera allergy, patient receives VIT extracts containing the actual Hymenoptera venom, So, in case of Hymenoptera allergy, patients, they receive VIT extracts, that is venom immunotherapy extracts containing actual Hymenoptera venom with a maintenance dose equivalent to 2 to 5 stings, with a maintenance dose equivalent to 2 to 5 stings. So that is about your venom immunotherapy. Next, you need to know what is the immunotherapy. Immunotherapy is a means of tolerizing the patient to the allergen. Tolerizing the patient to allergen. And this tolerizing the patient to allergen is by means of serial subcutaneous administration of escalating doses of extract containing relevant allergen. So, tolerizing the patient to allergen is by it is by serial subcutaneous administration of escalating doses. Serial subcutaneous administration of escalating doses, of extract containing relevant allergen until a target maintenance dose is achieved, until the target maintenance dose is achieved, you need to give the you need to tolerize the patient to allergen. That is by means of serial subcutaneous administration of escalating doses of extract containing relevant allergen. That is about the immunotherapy. Next, followed by that, for how long you need to give this immunotherapy? The recommended duration of treatment is 3 to 5 years. It should be given for nearly around 3 to 5 years. However, patients who have experienced severe respiratory or cardiovascular anaphylaxis, they are often on lifelong therapy. So those individuals who have history of respiratory or cardiovascular anaphylaxis, in these individuals you need to give lifelong therapy. That is about the duration of therapy. Next, we have one more modality of the treatment called tolerance induction. See, while the induction of tolerance at an early age seems to be a key to preventing the clinical reactivity later in the life. So, that induction of tolerance, whatever is there, should be done at an early age. And thereby you can prevent the clinical reactivity later in the life. It is not yet clear if this particular principle of tolerance induction holds true for other foods commonly associated with hypersensitivity reaction. But this induction of tolerance should be done at early age. So when you do it in early age, that seems to be a key to prevent the clinical reactivity later in the life. Next, coming to the desensitization. See, for patients who have suffered anaphylaxis from drug allergy and whose treatment regimen requires the administration of offending drug, the desensitization may be a short-term treatment option to prevent the reaction. So desensitization, it is a right, it is a short-term reaction event, right? For patients who ever have suffered anaphylaxis from drug allergy and whose treatment regimen requires the administration of the offending drug, desensitization may be a short-term treatment option to prevent the reactions. Desensitization elicits a temporary state of tolerance to the drug, right? It elicits the temporary state of right, it elicits the temporary state of tolerance to drug in sensitized clinically reactive patients. Okay, so that is about your desensitization, right? Next, followed by that, lastly, the pre-medication regimen. A typical pre-medication regimen for radio contrast, like for example, if the individual is having the allergy to radio contrast and radio contrast is mandate, I mean, for example, if that particular patient, if it is like mandatory, then you need to do or you need to give a pre-medication regimen before giving that radio contrast, and that pre-medication regimen that includes the steroids, that is prednisolone. And this prednisolone should be administered at a dosage of 0.5 milligrams per kg, right? And that has to be administered at, right, that has to be administered at 1 hour prior to contrast administration, right? 1 hour prior to contrast administration. And we have one more pre-medication regimen that includes diphenhydramine. So this diphenhydramine, the dosage is 25 milligrams. Even this has to be given 1 hour prior to the contrast agents. Okay, and you take vancomycin. See, flushing reactions are very common with vancomycin. See, flushing reaction from vancomycin can often be alleviated with antihistamine pre-medication and down titrating the infusion rates. So, if you want to ensure that the flushing reactions with vancomycin right, the flushing reactions with vancomycin, if they have to be alleviated, if they have to be reduced, then you need to give antihistamine pre-medication. Okay, or you need to do down titrating the infusion rate. So that is about the pre-medications, right? So to summarize the treatment once again, let me tell you, first and foremost, very important drug of choice will be the epinephrine, right? Epinephrine will be the drug of choice. And how much of the epinephrine you will give that? So you have to give 0.3 to 0.5 ml of 1:1000 epinephrine has to be given. Then next important is, what is the advantage of epinephrine? It will stimulate both alpha and as well as the beta receptors. Next, you need to know the empty heart syndrome. This epinephrine has to be given only in supine posture, not in sitting posture or upright posture. Epinephrine, when you give in supine posture, when you give it in upright posture or sitting posture, you know that the epinephrine will precipitate the empty heart syndrome. And the next important thing is, which antihypertensives will attenuate the response? That is, beta blockers should be avoided. And how will you treat intractable hypotension? IV fluids and as well as additional vasopressor agents have to be administered. Then how is your oxygen delivered? That is via nasal catheter or nebulized albuterol. And if it is not sufficient, then you need to intubate the patient or put on the tracheostomy. And then what are the ancillary agents? That includes as antihistamines, glucocorticoids, and as well as the bronchodilators. And very important thing is you need to avoid whatever the triggering agents are there. And this venom immunotherapy should be given in those individuals who had a large reactions with Hymenoptera sting. Then immunotherapy. Immunotherapy is tolerizing the patient to allergen by giving serial subcutaneous administration in an escalating agent. Then duration of this immunotherapy is almost like 3 to 5 years, and in those individuals who had a cardiac or respiratory anaphylaxis, they require lifelong therapy. Then the another modality is the tolerant induction. This has to be done at the early age, then followed by the desensitization. This will help you in giving the short-term reactions. The pre-medications like prednisolone, diphenhydramine, and the antihistamine pre-medication has to be given. So that will help in preventing the development of anaphylaxis whenever you are giving these contrast agents or vancomycin. So this is in detail about the anaphylaxis. Thank you very much.